Hey everyone, so I'm here at the Austin with Dr Alex Craven. I want to thank the team at the Austin for letting us do this. It's a pretty big thing for them to let people come in and do this kind of thing.
Yeah, I think public hospitals often are a bit wary of letting people come in and film, and I think everyone's waiting for a gotcha moment and ending up on the front page of the Herald Sun. But I think it's important that we show what we do, and I'm very privileged to do that. And so, yeah, I guess I'm pretty grateful to the team at Austin for letting us do this. So,
So the first time we met, I guess just in the course of the conversation, I told you that I'd had, at that time, I think I'd been sleeve I was about 11 years post-op. And I said that ever since I'd been sleeved, I had reflux issues and a few other things going on. And we got to talking about that.
And I was very clear to say at the time, I'm not your doctor, I'm your mate. I'm not giving you medical advice, but that's not normal. But yeah, go on.
Yeah, so I realised then that, it isn't fair of me to just, expect answers from professional when they're not the treating professional. So I made an appointment, did it all the right way, and came in and I saw you at your private clinic. And so what were your thoughts when I came in for that first appointment and we were actually able to talk about it?
Yeah, so I guess the first thing is, I think a lot of stuff gets bandied about. I put stuff on social media. Lots of us as doctors put stuff on social media. We say stuff in passing, and I think we often do that. And it's worth remembering that a lot of what we say is out of context. And really good medicine is about matching what we know as doctors to what you know about yourself. You're the expert in you. I'm the expert in the medicine or the surgery. And that needs to happen. And so there is sort of a process for that. And I think that's why, I was pretty cagey and I think that's the way things should be. If you're getting sort of free advice online from any kind of healthcare or pseudo healthcare professional, it's always a bit of a worry, if I like, and it is very generic. And so when I'm talking, I'm very careful to say that. So we sat down. So I guess the first thing is that we have a process, it's as old as medicine. The start of our conversation was really me. I would have said to you, look, first I'm going to ask you a ton of questions, half of which might sound like we're repeating stuff. I'm going to go into details that will seem unimportant, and then we'll talk. And so that's really about making sure that I know enough about you that when we talk about things, I'm not just giving you generic advice, but I'm actually giving you or making decisions with you that actually match your circumstances.
Yeah.
And so that would have been the first half of the consultation, was just me quizzing you. And the things that I'm looking for in that is there's the general health of the person, and we're very practiced and we take a medical history, and really that's just about encapsulating the medical issues. When it comes to weight, obesity and related disease, there are specific things that we want to know, not just about what's going on right now, but the history of that. So I would have asked you about things that worked for you, things that didn't work for you, things that were very comfortable and sustainable for you, things that were very frustrating, just in that general picture of that. And what I'm really trying to figure out is how your body responds to its environment in a way that is unique to you, because again, that is important when we go forward. Probably the most important set of questions I would have asked you, from my point of view, is about what we want to achieve and what goals and success look like. And so that was, the first thing we sat down was really, yes, you came to see me because I do obesity treatment and upper GI surgery and all those sorts of things, but ultimately at the end of the day, I need to know what you're after. And so I think at that point, and you were very clear on your goals at that point, you kind of had one.
I wanted to fix the reflux. And I mean, at that point I was sort of like, if I could lose a little bit of weight, that'd be cool, but I wasn't super focused on any more weight loss. Although it was in the back of my mind. And the type 2 diabetes had come back. And that's always been a big one for me. My dad had a close friend die from complications of type 2 diabetes, and so I've seen sort of firsthand what that can do. And for me, I progressed really quickly from just having a tablet through to 2 types of insulin a day, and quite a lot of it because I'm really insulin resistant. And I didn't want to get back to where I was on the 350 units of insulin a day to try and control it. And so that was the big one for me. And I'd always thought that bypass was the only choice. And I liked it when we sat and talked because you were able to show me even through the numbers that I'd had fantastic weight loss. And the fact that I'd been able to maintain it for a certain amount of time. But even though there was some regain there, it wasn't wrecking everything that I'd set out to do for my health. Because that was my thing. I thought, I've blown it, I've regained 25 kilos, and the fact that I'd lost 110 sort of meant nothing to me. I'd regained 25,
Yeah, and that's very common and normal. And human nature, we reset our expectations. So we get to a point, this is my new baseline. And of course, if your new baseline is set at your lowest possible weight, well, it's only up from there. And I think that's often forgotten. What we know, I guess, from a medical point of view is that when it comes to weight, that how far you come is much more important than where you stand in relation to where you started is the most important thing from a medical impact point of view. So, and we use this number, percentage total weight loss, which is percentage. And so you were right up there with percentage total weight loss. The interesting thing when you told me your numbers, in the back of my mind, I was actually thinking exactly the opposite to you. Because when I started hearing your numbers, there is, in my mind, as someone who works in this area, there's what we call sort of results out of context. So we have a rough expectation of sleep. And so in the back of my mind, I was like, that sounds a bit high. That sounds like a bit too much. So it's interesting that you and I had completely the same number. And I was a little bit like, I really need to make sure, I know what you do and all that sort of stuff. And we talk about, but so it was interesting because I was coming from the point of view of how far are you, like where are you standing in terms of where you started? And I was thinking to myself, how many times a day is he eating? How many of those meals containing protein and produce? Is there skipping? Is there, over restriction of caloric or food intake? Those things are running through my head. And so when you started giving me your numbers, I was actually screening you for all those kind of things because, first do no harm. I don't want to, great, I've done this great thing, but I've also left you with brittle bones and, no muscle to age with and all those sorts of things. So that was actually going through my mind. And as part of, any consultation, when I meet someone for primary surgery or when it's in revision, you're always going to get a nutritional screen. And you're always going to get me asking questions about your diet. And it's never out of judgment about, I'm never looking for, because you'll hear a lot of diet questioning around, where can I pinch calories from him? Like people will be like, are you snacking? And then when I'm asking, it's very much from the curiosity point of view of, first of all, nutritional resilience. So if you're going to go into an operation, I need to know not that you're just nourished now, but you need a bit of extra resilience. You need a bit of extra in the tank. So I know your nutrition's going to hold up to, and this is the same with medications. If I'm going to do something effective, I need a bit of fuel in the tank to know you get there. And then I'm also looking at, and when we talk, I will ask about things like snacking, but from the point of view of, I'm thinking about, satiety. I'm like, so what's his sleeve doing here? How's it responding to food? Is it still doing what a sleeve should be doing in terms of, with this portion of food? I know that should, I'll get a rough idea. That should hold you for a good few hours. Is that holding you, or are you snacking? Not because snacking's a bad behaviour, but because snacking is often a sign of loss of satiety effect, which sometimes we can treat without doing any surgery and without using any medications. We can actually augment that just through, that is something that we can augment with sort of diet and behavioural stuff. Again, not about caloric reduction, but about making this work well. So those are the sorts of things that were running through my head. So it's very interesting that you and I both came at the same number, and mine was like just a little, not a red flag, but just a little orange flag being right. Ooh, let's just make sure that we're getting in what we need to be getting in. And meanwhile, you were like, oh, it's all
So it was interesting with the my last blood test that you guys did. I was actually really low in iron, and so I had to actually have an iron infusion, which was done here. And fantastic team.
Did you notice a difference to that? Like,
I did.
You feel like you got a real...
Yeah, within a week, I was like, wow, I actually have more energy in the morning. I wasn't just sort of lying there going, did I even sleep last night?
Yeah. Yeah, so because I think we all know of iron as it relates to red blood cells. So we all know if you don't have enough iron, you get anemic. And then if you're anemic, you feel tired. And I think one of the things perhaps that's not out there enough is iron's actually a coenzyme for a whole lot of other reactions. It matters to muscle function, it matters to brain function, it matters to mental health and all sorts of other things. And so you don't need to have, just because you're not anemic doesn't mean you haven't got symptomatic iron deficiency. Yeah. And so having said that, I would say it's very hard to pick. Some people are like, oh, your iron's in your boots, oh my gosh, and give them an iron infusion. They're like, no, I'm still tired, I'm still a mum, I'm still working too much. But other people, really, that can often go unnoticed. And again, it's becoming something I'm seeing more and more with the online drug ordering, where you're just like, hey, give me a really effective obesity treatment. And then suddenly I'm just exhausted. And you shouldn't be like that with effective obesity treatment. You should have more energy. As you know, you should have more energy, more function. When we're doing this well, you shouldn't be exhausted.
That's something that concerns me with so much online and over the phone medical advice is sometimes our doctors need to physically see us. And I worry. I know there were times where I deliberately would do telehealth so that I didn't have to walk in and actually account for how I was looking. I could just tell my psychologist that I'm doing.
Of a vehicle registration DZS95A and full tremor, please remove from the entrance at the B1 car park. That's a Ford Tremor registration DZS958. Please remove your vehicle from the B1 car park entrance.
That's cool.
On the hazards of a public hospital. Yeah. Sorry, you were talking about...
So, I think when I was seeing my psychologist after I had a car accident and just getting help for some PTSD and stuff, I found that I could control the narrative a lot easier if I was doing telehealth. And there's really good points in our doctors, our health professionals, providers being able to actually physically see us.
I would say I don't think you need to see everyone in person, face to face all the time, but there is information you can gain from that. There is the physical examination side of things, absolutely. Having said that, in this, there are other areas of general surgery that I do where that's really important. If you've got a hernia, I've got to put my hands on it. But in this, I think often the impact on the person often outweighs anything I'm going to measure or weigh physically.
Yeah.
But having said that, there are a lot of things. We have this phrase in surgery called the end of the bedogram. And really what that means is, what's your kind of overall impression? You've been in the room with this person, where are we at? And it is actually something important. Also, there has been clear evidence since the time I was an intern that face-to-face communication is more effective than video-based communication, is more effective than phone-based communication. And so I think in those times when communication is important, we are taking a little bit of a step back. Now, having said that, telehealth is wonderful because the convenience of that and the ability to do that, lack of travel time, there are appointments where I'm like, oh my gosh, do not come and see me.
Yeah. Because
everything's going well. You will waste so much time in the car for us to high five and you walk out the door again. But I do
Especially
think
if it's
there's
going to be like a 5-minute appointment, you know, just to...
Yeah, but I do think if you're in that situation of thinking, and before the decision making, not after the decision's made, but I think before the decision's made about something as important as an operation or a lifelong medication, I do think that there's a value in that. That I think you've really hit the nail on the head on that. There's a real value in that, and I think you can balance the convenience. And I think the nice balance for a lot of people is an occasional face-to-face, mostly telehealth kind of works.
Well, I've loved the process with the Austin. I've come in for some face-to-face, but then there's been other appointments that they're like, no, it's fine, let's do. Yep. There was one that was a video. There was another one that was just over the phone, depending on who I needed to speak to at the time. And I think that's been great, and I think they really nailed it with the people that I needed to come and see face to face, and the ones that were just a phone call or a video chat. So you know, I think they're doing it really.
Yeah, I think for me, telehealth is a tool. It's really useful, but it's like telehealth a hammer. If you need a screwdriver, don't use a hammer. And I think the problem is when you are engaging with a health service that only has screwdrivers, you're stuffed if you need a hammer, and vice versa. So I think that the answer is to have a situation where you have access to it. And my worry is not about the use of telehealth. My worry is about having telehealth-only services without the ability when it's needed. And if you haven't got it, you're not going to recognise the need for it. And so I think that's my concern. I'm not even going to clinicians' work, that sort of thing. But it is like going to a carpenter and being like, oh, you've only got hammers.
Yep.
You know, it's so. Yeah. So anyway, we did all of that. I don't know, what else were we talking about? So where were we next? What are we going to talk about next?
Do we want to show the
graph?
Let's
talk about that. Yeah, absolutely. So this is something I do with almost everyone these days. This is not perfect. So this is a tool designed by a team in France. Yep. One of my biggest problems with it is that although the data they've collected, so they collected a bunch of data from all these registries, thousands of patients, 1, 3, 12 months, 24 months and 5 years. So that has then been processed, and they factored in a few things we know affect weight outcomes like age, starting weight, whether or not you've got diabetes, whether or not you smoke. And they came up with these good algorithms. I think the mistake they made was then they got AI to draw some lines in. And so I guess what I'd say is that some of these graphs are really wrong because AI doesn't really know what, AI hasn't done 200 sleeves and know what they do. So some of the lines in between are problematic, but overall I've found that those points, those 12, 24, 5 months points are really quite useful. And there's a couple of things we notice whenever we draw these graphs. Two things. One, wide range of outcomes. So we have an average, but then the range around that's very wide. So we know, and this includes people that have complications that haven't, but this is repeated in all the studies. There's always a wide range of outcomes. Same with the medications now. There's something about obesity where there's a lot of genetic variation, there's a lot of personal environment variation, we have a lot of variation in outcomes. But something that people often miss is there's less variation when it comes to more weight loss than less weight loss. So things that we notice about this graph, one, wide variation in all studies, wide outcomes, and now with the medications we're seeing a wide range of outcomes. Yep. Second is wider range of outcomes at the lower end of weight loss than at the higher end of weight loss. So if you like, when it comes to the average, the people that are above average are clustered a lot closer than the people that are, below the average. And so we should have a lot less tolerance for, we should be a lot more tolerant of not quite getting what we thought we would get in terms of weight loss than we should be about getting too much weight loss. So, and so that's something to remember. You be careful what you wish for. The other thing too is we have a concept in mathematics or in medicine called regression to the mean. And so what we tend to find is people that may lose more weight than we expect to start with are likely to regain more to come back to average. Meanwhile, with the other people where they think, this isn't quite working as well as we expected, but they lose weight slower over a longer period to end up about the same rate. And so you can get yourself all worked up if you're, such and such lost this much in in 1 year and I lost less than that, and if someone else is like, oh my gosh, I lost so much in the first year, that means I'm going to keep more off long term. Well, not necessarily.
Yep.
So that's something we'll look at, and so it helps people just reframe expectations. It's something that I do with all of my patients before all operations, and even do this and compare it to medication outcomes so people really know what they're getting into. They all forget. They're all still disappointed when they put on a little bit of weight, but at least we tried. But we get there. So that's what we looked at, and this is your numbers that we've put in here, and safe to say you're an overachiever from the point of view of weight loss.
Yeah.
Again, remembering that doesn't reassure me. That actually, if anything, worries me more than if you were a quote unquote underachiever. Yeah. And so when we looked at this, we could tell, in terms of the weight thing, not nothing much going on there. But the important thing that you and I spoke about is that when I look at this, actually, I'll turn this upside down. When we look at this from the point of view of the percentage of total weight loss, what we tend to look at is this is the percentage that you've lost. My aim in general for most people with real problems from obesity is about 20% or more. And I want them up there and I want them to keep there. Anything more than that, I'm feeling good about. In the setting of type 2 diabetes, I'm really pushing that up to more like 30%. I'm setting my bar a bit higher. And that's because in something like type 2 diabetes, you just got, it's a killer.
Yeah. It's
a really important disease. And unlike this weight thing that has a very gradual effect on risk, as soon as you develop type 2 diabetes, essentially your risk of dying doubles.
Yeah.
And so that's a really big thing, that's a really important thing. And so, when we talked about that and we talked about those goals, you had your goals, and then I sort of added a few of mine as a doctor. My job, reducing risk of death, is kind of the whole reason we have doctors around, I think. Those are the things that I'm really looking at. In other people, it might be mobility, it might be breathing related, it might be heart failure related, those kind of things. If we find something that says, okay, no, this is not just a weight thing now, this is something that is threatening people's life, then that goes on my list of, may not even be on your job list, but it's on my job list of things that are important that we need to look at. And so while we weren't interested in that, and I'm not interested at all in the weight thing, having seen that graph and knowing where you are and all that sort of stuff, in my mind was very similar to yours. This diabetes thing is a real problem.
Yeah.
The other thing too is, if you don't mind me asking, had you tried other medications for diabetes, and how are you tolerating those at this point?
Now I'm just on the Nova Rapid insulin and a long-acting one. And actually, since I've started the pre-op, I'm only taking the long-acting once a day. I was dropping down to like 2.8 and my phone was going off, and I was like, maybe I don't need the fast-acting one.
Yeah, so. and so that, like, you're talking about the very low-calorie diet, the formulated, So that's a very specific and, for pretty much everyone, non-sustainable diet pattern. It's really a short-term, and in the long term, there's a lot you need to juggle if you're going to keep that going long-term. It's different to bro keto, the keto diet over the internet, as you well know. And it is, in the short term, very good at keeping sugars low, but the problem is that it is really difficult to maintain long term and has its own problems long term. And so, but that's a thing we often see, and often when we do that, we've got to be very careful that we tinker with this. What about GLP-1s and other stuff?
So I had tried a GLP-1 and just constantly nauseous. Like, even after the the first titrate, and I just spent more time at the toilet or feeling like I was going to vomit than, so I'd actually reduced eating down to maybe once a day, and there were some days where I wasn't eating.
And you're still getting reflux?
And still getting reflux. So the GLP-1s, I just sort of went, what, this isn't sustainable for me at all.
And so that would, again, I can say this now, that was another little warning sign for me. So what we find is, with metabolic operations working in the way that they intended, I almost always find, well, in fact, I have never found someone yet that hasn't tolerated those medications very well. Now, I don't have to use them often because usually the sleeve is enough or the bypass is enough. But And I suspect the reason for that, and I suspect more evidence will come out to why that is, that and this is now something that I talk to my endocrinology colleagues about and other surgeons about. Everyone's like, yeah, GLP-1 works great after sleep. No one ever gets any adverse symptoms. We never have to use more than tiny doses. Like, that's the anecdotal feeling out there. I suspect what it is a lot of those adverse symptoms are because in the early days, particularly when you first start those medications, they really slow the stomach in particular down.
Yep.
And if a sleeve is working as it's supposed to, like we talked about last week, rapid entry, rapid exit, then slowing it down a bit doesn't kind of matter. You've still got a normal flow through. And so we find something we've noticed when it comes to doing anaesthetics and gastroscopies on people that are on these medications, with the sleeve or the bypass stomachs, we never really find any food left behind, which is actually a real concern if we haven't fasted people well. So that was a little observation that I made there. And the other thing that I'd talk about here is insulin is a real double-edged sword when it comes to type 2 diabetes. Too much insulin is part of the problem in type 2 diabetes. So it's part of the mechanism of harm. And there is a wicked cycle where insulin, part of the way it works in terms of lowering your blood sugar, is to encourage your fat cells to take up more sugar, therefore take up more energy, therefore grow. And it's not quite as simple as more and bigger fat cells, but essentially insulin feeds the biology of obesity.
Okay.
So it's necessary to keep your sugars low because that's really bad for you and it causes immediate harm to arteries, nerves, the rest. But at the same time, this is a little bit of, 2 steps forward, 1 step back, because you feed
the weight.
And I don't know what you notice, but most of my patients notice when they start on insulin, they almost always put on weight.
Yeah.
And one of the things I'm starting to notice too is when I see a patient that started on insulin, if I look back at other markers of metabolic health, liver tests, lipid tests, high sensitivity CRP, it's not always good news. So the HbA1c's come down. That is a 3-monthly test that marks sugar control. That's come down. But some of these other things are often getting worse on insulin, despite that, which is a concern. It's the whole health picture we want. We never want to look at one number. And so, in my mind, when we're talking about diabetes, the sooner we offer metabolic surgery after diabetes starts, the more likely we are to make it go away, what we call remission. Not really cure, because I don't think it fits the definition of cure, but like having cancer in remission, it's not an issue. Ideally, if you can operate on someone when they're in the pre-diabetes phase, which is already causing lots of harm. So pre-diabetes in itself is a disease. It's causing harm to the body. Really, type 2 diabetes is when the pancreas is completely failing and we're trying to prop it up with all lots of other medications and replace the insulin and stuff. So if we can operate before that complete sort of pancreas failure, if you like, then even better results from that point of view. But then after the diagnosis, we see in the first year like 90% remission. And then it sort of comes down year after year. So the longer you've had the diabetes, the less likely we realistically are to make it go away with any sort of metabolic surgery. The other thing is how much medication you need to control your diabetes tends to tell us a bit about how it's going to respond as well. So when you came to me like diabetes back, like realistically, you've had it for a long time, really long time. About the doses that you talk about are very clear evidence of severe insulin resistance. And so when we talked about that, we're like, well, maybe I don't think a realistic goal is diabetes remission here. I don't. But no insulin is a really good outcome for people with type 2 diabetes. Injections suck and measuring your sugar sucks and all that sort of stuff. But actually, in someone with obesity and diabetes, not having insulin driving that cycle is a good goal in itself. And so that's something we parked as a thing. And then the other thing is, if I can get to a situation where you can tolerate other options, so we can still achieve that sugar target without insulin. And one of those would be creating a situation where you can tolerate GLP-1 in the future. And so that was another thing that was going through my mind, I guess.
And that's See, I think I've learnt enough to know that sort of, I guess, what might work for one person may not work the same way as someone else. So we just have to keep those options open and be willing to explore all options to get the best possible outcome. Yeah, and I think if the diabetes is a lot more controllable, and I'm not waking up at night with sort of acid and stuff coming out my nose, and then I'm going to be happy with that. Even if it meant that I still had to take some sort of reflux medication, but where it actually worked would be amazing.
And that's sort of what we talked about. We've got levels of reflux. We've got uncontrollable, medication-resistant reflux with esophagitis, right? Okay. Then if we can get to reflux that has no esophagitis, well, that's a bit of an improvement. If we can get to reflux that is well controlled with medications, well, there's another step in the right direction. If we can get to reflux that's well controlled with occasional instead of regular medications, then we're there. And if we can get rid of reflux entirely, fantastic. But and that's the sort of thing we talked about. We're not, and unfortunately there is a reality in statistics. We kind of make a best guess on what we think will happen. We'll go from there.
So when we spoke, you ordered some tests. One was a fizz.
Yeah, how was that?
Oh, that was horrible.
Sorry.
They're like, bring a can of Coke with you. And I'm just like, what are you going to make me do with this?
What are you talking about?
And she's like, she comes in just so casual. And I need you to drink that whole can as quickly as you can. And I'm like, bitch, do you not know? So,
and they tap so politely. Like,
it's just like, I'll do your best, and I'm like, you're way too nice to be delivering this sort of. Crack the can open. And if I'd have known, honestly, I would have probably opened the can on the way there and let it go flat a little bit. But,
well, that would have defeated the purpose.
It would have defeated the purpose. So, I cracked the can and trying to scull it. Oh, the pain, it was just like ripping my chest open. And I managed to drink the whole thing in like 20 seconds.
Oh, mate.
And she's like, okay, now we're going to do it. I'm like, just do the scan. So,
that sounds like we've gone vomit or slurp or something.
Gets it done and comes in. She's like, okay, you can go now. And I'm like, thanks. I'm not thanking you today. So, and then I'm thinking, bloody Alex.
I did warn you. So that what that is. So technically, I guess you'd more call it a negative contrast, which means we use the gas to show it. A negative contrast distension CT of the stomach is what we could call that. There's a few ways to do it. The fizzy stuff, you can actually put down a tube and squirt air in. I don't think anyone does that outside of weird research studies. So essentially that's sometimes people get like you drink a cup of one thing and a cup of another, and it's a little bit like the vinegar and baking soda reaction. And so you think, that was only like, I only drank 30 mils. And then you feel it. So whatever it does, so that stretches up the stomach. And so the reason for that is when the stomach's lying floppy and flat, it doesn't really tell us much. It's not a great organ to image on scans because it kind of flops closed and it's not really helping. So we do that, and we would have done a gastroscopy as well, and we always sort of do them in concert. We do them together. One, because when I do a gastroscopy, I push a gastroscope down, and so I actually distort the anatomy when I do that. And so what I see may not reflect what things were like when I wasn't pushing something through. And the other is in the sleeve stomach, it's often we can't as reliably see certain structures, particularly those outside the stomach, like the diaphragm, and so figuring out exactly where things are relating to the diaphragm, etc. And so we combine the two. Neither one by themselves is complete. We don't always need both, but often the two go together. And then we sometimes, I don't know if I did this to you, I think I was very happy with the degree of reflux and the symptoms you had, that's what it was. But it's worth remembering that not everything that feels like reflux is reflux. So sometimes we will need to make sure it's actually reflux, because the esophagus doesn't really tell us what's going on very well. It's like, if it's a movement disorder or a tumour or reflux or whatever, it kind of feels the same. And so sometimes we'll send off for formal pH testing to get an idea of that. And other times we look at the way the esophagus is moving and making sure it's not squeezing erratically, failing to open, all those sorts of things. So there's often a bunch of tests to do. And then, and that really then is all based around on reflux is complex. Reflux after sleeve is an added level of complex. In general, what stops reflux normally? Well, first of all, we all have a little bit of reflux. All of us have a little bit of reflux. But what stops that being a problem for us is we've got a complicated valve system. So the bottom of the esophagus squeezes a bit. There's some muscles in the stomach that squeeze down. The esophagus enters the stomach at a bit of an angle, so as the stomach fills up, it sort of squashes things over. The bottom of the esophagus sits down in your belly, so when you squeeze or cough or do things and put some pressure on that, yes, it squeezes your stomach, but it also squeezes your esophagus closed at the same time. And that's all held in place by a bunch of ligaments and soft tissue that holds up to the diaphragm, and the diaphragm, should be snug but not too tight around the esophagus, all this sort of stuff. So there's a lot going on there, and it can be one or a combination of all those things that causes reflux. And then with sleeve, what we can see is, because we have a narrower stomach, there can be a bit of back pressure, but even without that back pressure, one of the things that happens when we swallow is called receptive relaxation. So the stomach sort of accepts the food, catches the food, if you like. That's not going on in sleeve. So there's a few other things that can happen. And so what the long and the short of it is, after sleeve, some people's reflux gets worse, some people stay the same, some people gets better. We lost that. We'll call it again later. But we probably can do enough to get a decent idea of who's who. And so some people, they'll have no reflux, you put a sleeve below it and they start having reflux even though they never had some before. People who already have reflux, weight gain can make reflux worse and weight loss can make reflux better. And so although people think, sleeve causes reflux, there's a group of patients for whom it's really good for their reflux, because as the weight comes down, their reflux goes away. And then sometimes the cause of the reflux is what we call a hiatus hernia, where the top of the stomach slips up into the chest. And so then if we fix that, then do a sleeve, or we fix the reflux. But sometimes it doesn't fix the reflux because it's more complicated than that. So there's a bunch going on. And what it comes down to is there's probably a group of people that are very unlikely to get reflux, or if they do, it'll be pretty mild. There's a group of people that are almost guaranteed to get reflux after sleeve, and there's a group of people in between. And then the last thing is, reflux is really horrible for some people and not horrible for others. The sensitivity to reflux differs from person to person. So the people will be like, I get a reflux, but I don't really feel it. And then the other people that get very little amounts of reflux and get horrible symptoms, and even what we call reflux hypersensitivity, where you're actually getting normal levels of acid, but you get horrible symptoms. So it's even worse. So there's all that going on. And so what then, we look at, there may be some unfixable issues at the bottom of your esophagus that we can't fix it. But there are some things we know contribute. Little hiatus hernias don't tend to matter much in the normal stomach, in the unoperated stomach. Little sliding hiatus hernias, tell the medical students, ignore that, treat the reflux or don't treat the reflux. That hiatus hernia is not really where the excitement's at. Any hiatus hernia in a sleeve is abnormal, because it's much more likely to cause symptoms. And in some people, that hiatus hernia will cause reflux. In some people, it will cause reflux and also loss of the sleeve effect. And so you have some people who get a hiatus hernia. Not everyone loses their weight loss when they get a hiatus hernia, but some will. And so that's something we look for, that hiatus hernia. The next thing is the shape of the sleeves. As I said, we talked about, we want a sleeve that essentially is going to narrow at the top and gets wider as it goes on. And we want that so it empties quickly. We don't, partly for its therapeutic effect, getting stuff to the duodenum quickly, but also we know that that's associated. If there is that hold up, then over time the top of the stomach's the stretchiest, and that will stretch up. And we think that there's two issues with that. One is you get this back pressure effect, but also often the back of the stomach is more stretchy than the front. And so it probably distorts as that stretches up. It does so it's a bit skew if it's a twist, if you like, in a way that probably promotes reflux as well.
Okay.
There's a bunch of things going on there, so that's what we did.
And so I've got like 600 and something.
Respond blue, radiation oncology, level 2. Respond blue, radiation oncology, level 2.
So I've got like 600 and something mil of excess fundus sitting there. I think that's what we found in the
one of the things we do is calculate the stomach volume. There is an average stomach volume 1, 3, 5 years after sleep. We probably don't have any good long-term data on what average normal sleep volume is. You were talking 10, 11 years ago in your case.
Yeah.
We don't really know. So that volume, there's a lot said about that. There's a lot of talk about that. That volume to me is much less important than what I call the morphology or the shape of the sleeve.
Yeah.
And so while yes, that number is a bit high, if that number was a bit high, but you had an overall, what am I trying to say, consistent shape to the sleeve, if it did have that shape where, it's just a bit big, but it is not narrow in the middle, it doesn't narrow down towards the end, it doesn't appear to be ballooning up, it doesn't have a hiatus hernia, and if you were well, if you didn't have the reflux, that number I would tell you to ignore. So that number, because I think there's often, people, and the standard error, the measurement error there is very wide. So how you does it, who does your scan will very much affect the number that you get. How quickly you drink the Coke or the other stuff or what they use will affect that number. And I've seen, wild fluctuations in people that have had multiple this done. I'm not sure really why you need to do it again and again in short order. And there can be 200-300 mils difference between the two. Wow. So there's a lot of variation in that number. So that number, it is a bit high, but it's, one number that you could put a lot of emphasis on that number for not much benefit. In your case, what was more important, I think, and we've already discussed that we're going to break your privacy and I'm going to go through your images, but so this one probably shows it better. So what I noticed was up the top here, very wide. So this is as if we've cut you through a deli slicer.
Yep.
And it comes down and very wide. This is the bit where the stomach turns a corner, what we call the incisura. And it is substantially narrower around that corner. And nothing exists on radiology unless we see it in two planes. So looking at you front on as well, very wide here compared to a much narrower, there's the corner there, and that's a relatively narrow point around the corner, but there is a caliber change down here. And so that's the bit that, when we talk about these things in the meeting, that worries me more than the number. And so, you did have a very small sliding hiatus hernia there. And all sleep hernia, all hiatus hernias in sleep matter to me. And so we talked about the possibility of repairing that, because otherwise your sleep is doing good things for you and all the rest of it, for all the things we've discussed. But the problem is that I suspected that in a situation like this where we have, really the question is, do we have a hiatus hernia? Yes, no. Do we have a morphologically normal, anatomically normal sleeve below that? It's going, no. And so that's where the decision making goes then, is well, yes, we can repair the hernia, but it may not be the key cause of symptoms, and that repair may be irrelevant or only very temporary if this is just going to keep distending from below and pushing it up. And that kind of, sort of sealed the deal a little bit. Like we sort of sat down and went, ugh, we can't, this isn't something that is likely to get better without reshaping the top of that stomach, and taking away that pressure differential, that diameter change, and that's where bypass comes in.
And for me it was it was a no-brainer after that. You know, if I've got to undergo such a massive procedure, you know, let's just do the revision and be done with it, than something that may have to be redone again.
And that's, you know, that's something that, again, you know, careful decision making around, because you know, sleeve and bypass aren't the same experience. They're not the same in terms of normal eating pattern and what we expect and what you will and won't get away with in terms of eating. They're not the same in terms of nutrition. And we haven't ever proven the same massive health impact from the second operation as we have from the first. So the first metabolic bariatric surgery someone has makes a massive difference to their health. Increased life expectancy, you know, you live longer, massive impact, positive impact on quality of life, all the rest of it. Pretty independent of weight loss. Just having the procedure, whether you lose any weight or not, has a lot of benefits, measurable, you know, real hard medical stuff type benefit. The second operation, you know, and in your case, it's a perfect example. You've already got that 20+% total weight loss. In fact, even more. So you know, in that situation, we're really looking at, you know, we've got some goals here, but we've got to be, and that's you know, where it takes some careful to and fro and some careful decision making, and that's why we then throw you at an education session. And there's 8-week program and a dietitian and a psychologist and some psychological screening, because and it's not about putting barriers in your way that you have to jump over. It's about having you as ready as we can and making sure that this is the right thing for you overall.
I think a couple of the real eye openers for me during this process was I'm now on a vitamin D tablet because my D was just so low, and I'll probably always battle with that. So, you know, I've got that in my regular everyday is a vitamin D, but I sort of had to come to accept that there's going to be a change in the way I have to nutrition myself and make sure I'm getting the right nutrients after surgery, because I'm guessing that's going to be very different to what I've had and what I've gotten used to even. You know, suddenly I'm having weight loss surgery again, and it's like... You know,
The good news is that the early recovery and the early return to eating after bypass tends to be a lot quicker after bypass and sleeve. We tend to see people get going a bit quicker after bypass, if you like, and I hope that'll be the case for you. Bypass has its own peculiarities. Bypass comes with a few risks and symptoms that sleeves just doesn't come with. In a day-to-day setting, bypass really likes to be fed regularly in a way that a lot of us with our busy lifestyles, I don't think I could run a bypass. I get distracted, skip a meal here, make up for it with a double meal later, snack on the run. I'd be a nightmare bypass patient, I'm the first to admit. And so there is, you know, it doesn't have to be perfect. You know, with a good metabolic operation, pretty good most of the time is all we're after. But there is an aspect, you know, that nutritional resilience. It really matters. Being on that upper edge of weight loss, losing a bit too much weight after sleeve is much more tolerable than bypass. People that have lost too much weight after bypass, it's probably the main reason I see dumping. And people often fail to appreciate that and eat less and make things worse and worse for themselves. There's a bunch of stuff you got to get used to. And so the education, and not just the education, I guess, the time to adjust, someone to touch base with and double check on stuff, it matters a lot.
I think something that I do hear a lot from people that have gone from sleeve to bypass is, you know, they don't feel the fullness that they did when they had sleeve. But the need to regularly eat, I think, is one of the big things, and I think it's a bit of a mind fuck for people because they feel like they're eating too much now, and I'm going to regain weight because I'm eating so much.
Yeah, and I think that again raises the point. This whole restriction idea. It's not even clear from exactly who means what when they say restriction, but certainly bypass, the comparison between bypass and that sleeve and that band experience that a lot of people have, it's worth remembering that bypass overall tends to create more weight loss and have more therapeutic effect than sleeve or band, yet come with less of that uncomfortable hold up to food feeling that if you take two mouthfuls too much early after a sleeve, and boy, so that idea you don't need that, and the idea of these operations is to reduce the minimum amount of food you need. It's actually not very good at reducing your maximum food amount, but often that's not explained well, particularly in people that haven't had that relationship with a dietitian, that long-term follow-up. We particularly see a lot of it, with the sort of the return traveller from the overseas surgery, and often the level of aftercare is zero, and so they're sort of left to figure things out for themselves, and that can often end up eating into sensation. And if you eat into sensation, that sensation wears off over time, then you end up eating more and more and more. And so we don't want that eating into sensation. We want that eating for satiation. And so there's a few things like that working with a good dietitian really
Actually, it was interesting after our conversation the other day about restriction, because I didn't realise, and there was a couple of things that you said that made me realise that I think when surgeons talk about restriction, it's a different concept to when patients talk about restriction. And
Definitely.
For a lot of patients, we look at restriction and go, it restricts the amount that I can eat by making me feel sick quicker, or that overfull feeling. And so many of us look for that because it's like a comfort thing.
Yeah, I could easily see that.
And especially people that have lap band to bypass, they talk about the restriction as, I can only eat 3 teaspoons and then I'm feeling sick and vomiting. And then suddenly I have bypass and I can eat a cup, and I don't have restriction anymore because it's not restricting the amount that I eat. Whereas I think when surgeons talk about it's restricting the amount that is going through the sleeve or the
and even I talk about texture versus volume restriction. So in my practice, you should never have texture restriction. You should be able to eat all textures. You should have volume restriction, but also I never really want you to find it. If I can help you navigate this so that you never actually find volume restriction, then we've done a really good job, because it's working metabolically without adverse symptoms. Because restriction is actually, I think most of us would agree, is actually a negative symptom. And certainly we have another number of procedures that can provide some metabolic impact and restrictions. So we can wrap bands around things. We can do the adjustable band. So a lot of people would be out there with an adjustable gastric band that was never adjusted. It's empty. And they'll be maintaining 10-15% total weight loss. And that's as good as the lifelong Wegovy, right? That's a good, impactful obesity treatment. Their pre-diabetes has gone away, their diabetes has gone to pre-diabetes, and now diet control for 10, 20, 15 years. So there is a metabolic effect from that lap band. That was often missed, because when we could add restriction to that, and the anecdotally what we see with that is if we add that restriction, then we get those back pressure issues. The reflux valve starts failing, the top of the stomach starts stretching, the esophagus itself gets a bit floppy, loose, etc., and then we start getting those symptoms. And that can often be reversible. So restriction, it's got value. It does work for weight loss. It does work for certain things, but it does come with some negative effects. The metabolic impact has some, much less important negative effects. In fact, there's very few I've managed to find in the metabolic component of these operations. The metabolic aspects are really, really good with minimal effects. And it's a little bit the same with the malabsorption thing. We can do procedures with very long bypasses, and we can create a bit of diarrhea and malabsorption, that sort of stuff. That comes at a real cost. Meanwhile, we can do bypasses with a modest limb where we can get the metabolic kick and not step into that malabsorption. And for most people, that's enough. There are people for whom we really need to push the boundaries. Often that's because their health was neglected by their treating professional for so freaking long that, after 20 years later, after they should have been referred for bariatric surgery 20 years ago, they finally find their way to getting obesity treatment, and you've got 20 years of damage. And often then we do need to be looking at some extreme stuff, and it's really sad when we need to do that. And we're using a lot of combination therapies and dieting and doing all this stuff. I think the answer is to do the modest, very effective metabolic procedures earlier and try to avoid that. But that's just me.
Yeah, no, that's amazing. And so I've it's really sort of something that I've been thinking a lot about since our last chat, because we sort of talk about you should be eating up to half a cup or whatever that is, and you were saying last time about the minimum amount to get through to the next meal, rather than needing to snack 2 or 3 times.
And I think it's easy to get trapped into. Here we go.
Medical emergency team, Ward 6 East, neurology unit. Medical emergency team, Ward 6 East, neurology unit.
So I think we tend to chase extremes. So we either go to as little as possible, and we restrict our meal size as little as possible, and other times we'll maximise that meal size. This is what will fit, and I think it's not right or wrong, but there is a way to dance in the middle. It takes a bit of knowing your body and adjusting over time, but I think you can play in that space of enough but not too much. But it's a learning process, and I suspect it changes over time as well. Like I know it changes in the first 6 to 12 months. I suspect it changes again in 3 and 5 and 10 years. And so I think having that relationship with your body and relationship with food, and then someone like a really good dietitian to check in occasionally and just double check you're getting what you need and help you adjust is probably the way to go. For most of my patients.
No, amazing. Thank you so much for doing this today.
Pleasure. Good to have you, man.
It's been great. So hope you guys have got something out of this, and
hope it helps.
I'm actually really excited. We're going to be, all going well, recording the bypass, and then we're going to sit down and talk through.
I'm embarrassed to say that it will rely on technical equipment issues. I want to, but I'm
fingers crossed. But if it works, then that's the plan. We'll be able to sit down and talk through the bypass. So stay tuned.
The other thing too is if any of this brings up questions, people can